Thank you. Good morning. We are 5 minutes late, so may I reduce my talk, or, I ask the moderators. Okay, we speak about film responsiveness. Film responsiveness, I'm just to declare as a member of the Medical Advisory Board of Pulsion, which is now Göttingen. And as you know, the decision to start fluid administration should be based on the presence of 3 elements, only 3. The first one is the presence of hemodynamic instability or peripheral hypoperfusion, whatever the clinical signs or biological signs, motor skin, hypotension, oliguria, hyperlactatemia, etc. This is mandatory before giving fluid. The second element is the presence of preload responsiveness. And you know what is preload responsiveness if you refer to the Frank-Starling curve. This is a systolic function of the heart. This is true for any of the 2 ventricles. You have the stroke volume on the y-axis and the ventricular preload on the x-axis, and you know the shape of this curve, which is not linear but curvilinear. And preload responsiveness is associated with the steep part of the curve, and preload unresponsiveness with the flat part of the curve. And when the heart is preload responsive, in general, the patient is fluid responsive. When the heart is preload unresponsive, in general, the patient is fluid unresponsive. As you know, not all patients in ICU are fluid responsive. This is a series of papers which were pulled in this article with Frédéric Michard, and we observe that for 400 patients with shock, only 52% of them responded to fluid administration. And this was defined by an increase in cardiac output. Another element which is important before making the decision to give fluids to patients is the limited risk of fluid overload. Because we know that fluid overload is not good. This is one of the papers showing that the community fluid balance is associated with increased mortality. This is a SOAP study, but there are other papers showing exactly the same results. So this is why we need predictors of fluid responsiveness, or I would say predictors of fluid unresponsiveness to help to choose the best fluid strategy by avoiding to fluid overload patients who would be fluid unresponsive. If I refer to this Frank-Starling curve, I would say that there is not one single Frank-Starling curve, but a family of curves between a normal heart and a failing heart. Therefore, it's not possible from a given value of preload, a single value of preload, to know if the patient is associated with preload responsiveness or preload unresponsiveness. And this is why assessing preload is not assessing preload responsiveness. And this is why static measures of preload cannot reliably predict fluid responsiveness. And this was confirmed by many studies. This is a famous meta-analysis by Paul Merrick and co-workers showing in 1,800 patients, it's not negligible, that the summary area for the prediction of fluid responsiveness using a single value of CVP was 0.56. And you know that 0.56, it is very close to 0.50. And this is like tossing a coin. This is why it is not recommended to start or to predict fluid responsiveness by using a single value of CVP. And this is what this consensus conference paper said. And many of the authors of this paper are here on the podium, on the first row. And with Maurizio Cecconi, we said we recommend using dynamic over static variables to predict fluid responsiveness when applicable. And now the surviving sepsis campaign also said, we suggest that dynamic over static variables be used to predict fluid responsiveness when available. So we have now, I would say, a consensus about this. What are dynamic variables? In fact, the dynamic variables are assumed to give some idea about the slope of the Frank-Starling curve at the time you decide to give a treatment or not. And the slope can be defined if you have at least 2 points. So you need 2 points, and to have 2 points, you need to test moving the preload. And you have, at the same time, the calculation of stroke volume or cardiac output. You can have the slope. And we can use heart-lung interaction indices to do this. We also can use passive leg raising. What about heart-lung interaction indices? We have now many categories of these heart-lung interaction indices. The first one, the most popular, is to use the respiratory variation of stroke volume or surrogates as pulse pressure, for example, because pulse pressure reflects stroke volume. But for this, we need mechanical ventilation. We need patients receiving mechanical ventilation and well adapted to their ventilator. And we can assume that if we have a high variation of stroke volume or pulse pressure, the heart is fluid responsive. If we have a low pulse pressure variation or stroke volume variation, the heart is fluid unresponsive. This is the hypothesis. And this hypothesis was confirmed in many studies. One of them, the first one for PPV, was this one. With Frédéric Michard, we compared PPV to PAOP, which is a wedge pressure measured by the PA catheter and also the CVP. And we compared the ROC curves and the areas of the ROC curves, and you can observe there is a big difference between the area for PPV and the area for the filling pressures. So we concluded that PPV predicted very well and better than the filling pressures, preload responsiveness, and fluid responsiveness. Also, others confirmed, and this is one of the meta-analyses about the prediction of fluid responsiveness by PPV, coming from a Chinese group, and they included 22 studies. It's not nothing, 22 studies, and 800 patients, so not negligible, and they found that the area under the curve, the summary area was 0.94, and the threshold value for PPV was 12%. Now, it's possible to obtain the value of PPV automatically, and it was possible from these hemodynamic monitors, so-called functional hemodynamic monitors, and the value is automatically calculated and displayed in real time on the screen. Also, it's possible now, as you know, to use some devices able to calculate stroke volume or to estimate stroke volume from the analysis of the arterial pressure waveform. And also, it's possible from this analysis to obtain the value of stroke volume variation. And all these devices are on this slide. And also, it's good. These are two meta-analyses comparing PPV and SVV. Many studies were included, and in general, the value of SVV also is good, around 0.88 for the area under the ROC curve for the prediction of fluid responsiveness. It is also possible to do this using the very simple plethysmographic signal, using pulse oximeters. And this is a non-invasive device, so very easy to use. And the team of Massimo Antonelli from Rome also performs this meta-analysis, showing that the area under the curve for the prediction of field responsiveness using this variability of the plethysmographic signal was good, 0.85, which is more or less as we found for SVV. It's not perfect, but it is good. It's not perfect because in some patients receiving vasopressors, and for example, norepinephrine, it is not as good. This is a study we did with Xavier Monet in our unit, and we found that PVI, which is a pleth variability index, which is one of these indices used using the pulse oximeter, was not as good as PPV and SVV to predict field responsiveness. So probably in patients receiving vasopressors, we have to be very careful about the use of these indices. It is also possible to use ultrasounds, and if you use ultrasounds, the easiest way is to look at the variability of the inferior vena cava diameter. And with Mark Fessel, we showed that this variability was good in patients receiving mechanical ventilation again, and we found that the variation of 12% during mechanical ventilation was a good predictor of field responsiveness. Of course, we have many limitations to use these heart-lung interaction indices, and especially these variability indices. We need sinus rhythm, so we cannot use in case of arrhythmias. We cannot use in case of low tidal volume, or we have to be very careful. And of course, by definition, I would say we cannot use in patients with spontaneous breathing activity. But we have other tests. For example, we can use end expiratory occlusion test, which is a test consisting in interrupting the ventilator at the end of expiration. And you can do this for 15 seconds. And you can prevent the decrease in venous return which normally occurs during insufflation. And the heart senses this situation as an increase in venous return. This is like a preload challenge. And if you perform a preload challenge, you can identify responders to field administration by patients who increase their cardiac output during this preload challenge. And this is what we did with Xavier Monet using the PICO system, the pulse contour system, cardiac output measurement, and we observed that patients who increased their cardiac output during this maneuver were the same patients who increased cardiac output after fluid administration. And this was true for the opposite. And it works well in situations where pulse pressure variation does not work very well. For example, in patients with low lung compliance, PPV is not good, the area under the curve is not good, but the effects of end expiratory occlusion on cardiac output are still good. This is a new study, not published, just submitted, where we try to combine end expiratory occlusion and inspiratory occlusion. With Mathieu Josviac and Xavier Monet, we did this in a series of patients, and we redid the end expiratory occlusion test, and this works very well again, and we found a cutoff for 5% for the increase in cardiac output, but we also performed an inspiratory occlusion, and we observed very good results. Patients who decrease their cardiac output by more than 8% were patients who will increase their cardiac output after fluid administration later. And when we combine both, the absolute value of both, we found good results, 13%. Why we combine? Because some devices have no, precision enough to detect small changes like 5%. because the variability of the intra-individual or inter-individual variability of these devices are not as good. If we combine, we have 30%, and 30% is above the variability of all these devices. So I would recommend to combine instead of using one. Another test is tidal volume challenge. It is also a new test. Because in case of low tidal volume, pulse pressure variation is not good to predict responsiveness. Not good means that if you have a low value, you cannot be sure that the patient is preload responsive or not. If you have a high value, okay, you can be sure. But if you have a more or less low value, you cannot be sure. This was demonstrated by this study by one of the chairmen, Daniel De Backer, and you see that the area under the curve is not as good in case of low tidal volume in black, but also the threshold value was lower, 8% compared to 13%. This is why we tried to overcome this limitation, and with a team of Mumbai, with Professor Sheila Mayatra, we tried to perform a study by making the hypothesis that if we increase tidal volume transiently from 6 to 8 ml per kilogram for 1 minute only, maybe we can predict responsiveness using only PPV. We confirmed that at 6 ml per kilogram, PPV was not good, and the area under the curve was 0.71. When we increased tidal volume for 1 minute, and we measured PPV, the value of PPV at 8 was better than the value of PPV at 6. But what was further better was the delta, the changes in PPV from 6 to 8. I can take an example. If you have 7% at 6 ml, and you increase tidal volume, and you obtain 11%, you can say the patient will be fluid responsive at 6 ml. And the threshold value we found was 3.5. And it was better than PPV 8 in terms of sensitivity. So I would recommend to use this to look at the delta. It is very simple to do. Also, we can use passive leg raising. This is a test you can use in intubated patients or non-intubated patients, whatever. And this test consists in moving not the legs of the patients, but the bed of the patients from a semi-recumbent position, which is a natural position in the ICU, to a position where the trunk and the head are horizontal and the legs elevated at 45 degrees. And this maneuver is able to transfer venous blood from the legs compartment, but also from the abdominal compartment towards the intrathoracic compartment. And this increases preload. In this study with Thierry Boulin, years and years and years ago, because we started these studies in the 90s, we measured cardiac filling pressures during PLR, and in all patients, almost all patients, right atrial pressure as well as POP increased during this maneuver. So this maneuver is able to increase preload. This is a preload challenge. And it mimics fluid challenge, and you have to look at the hemodynamic response to this test to predict the hemodynamic response to volume administration. It provides a good prediction of fluid responsiveness. This is a recent meta-analysis with Xavier Monet and Paul Merrick, and we included 21 clinical studies and almost 1,000 patients who studies that address the issue of fluid responsiveness using PLR, and the changes in cardiac output during PLR are very well predictive of fluid responsiveness. The area under the curve was 0.95 and threshold value 10%. We are very lucky because 10% is easy to remember. And also, unlike fluid channeling, the effects of PLR are rapidly reversible. Look at the decrease, the return to baseline of feeding pressures just a few seconds after stopping the maneuver. And also, it can work in situations where PPV fails to do it. For example, in patients with spontaneous breathing activity. PPV cannot work very well. Of course, this is the area under the rho curve, very poor. And in these patients, the effects on cardiac output of passive leg raising were very good to predict fluid responsiveness. And also in case of low lung compliance, PPV cannot work very well in case of low lung compliance, but PLR can still work very well. And of course, there are some limitations to use PLR. We know that during this maneuver, we should avoid sympathetic stimulation, because if you have sympathetic stimulation, you can have an increase in cardiac output, which is not due to the maneuver, but due to the sympathetic stimulation. And for this, you have to move the bed and not the patient, and you have to monitor heart rate to be sure that there is no huge sympathetic stimulation. Also, you should start from a semi-recumbent position, not from the horizontal position. This is what we confirm in this study with Julien Jabot. And also, we cannot monitor, we should not monitor the effects of arterial pressure. It is better to use cardiac output, because as you can see, the area under the rho curve for the blood pressure was not as good as the area for cardiac output, only 0.77. It's not bad, but it's not excellent. And we need a real-time cardiac output monitor. Whatever. And the last question, the last 30 seconds, I want to answer the question, do patients benefit from dynamic markers of preload responsiveness? I would say in the OR, or operating room, yes. Many studies showing a decrease in the complications rate, decrease in morbidity if you use these indices compared to standard care. Also, in the ICU, there is this very nice study by the group of Claude Guérin in Lyon in France. They compared two strategies, one using the CVP and one using the dynamic parameters like PPV or PLR, and they found that lactate decreased more and earlier in the preload dependence group. Also, less volume of fluids were given in the preload dependence group compared to CVP, and also the mortality was almost different. The p-value was 0.07, probably because of the lack of power. They included only 60 patients. So my conclusion is the decision should be based on these three elements, and the decision of stopping also should be based on the presence of either disappearance of shock or appearance of preload unresponsiveness or appearance of fluid overload. So my conclusion is that we should need these predictors of preload responsiveness, whatever PPV or SVV, or the response of real-time cardiac output to PLR or to end expiratory occlusion, because they are helpful to assess the best fluid strategy by identifying patients eligible for fluid infusion, and also by avoiding to fluid overload patients who would be fluid unresponsive. Thank you very much.